One thing that I think really differentiates my practice is at this point, 10 years in, fellowship training, teaching other surgeons, is that I get a large number of referrals for complex and revision procedures. In the knee, for example, those are often cases that fall under the rubric of joint preservation, meaning someone's had a prior sports injury, and for example, they've torn a ligament and damaged their meniscus beyond repair, and they've got a cartilage defect and maybe an alignment issue. And so we have to factor all of those things into our surgical planning, and sometimes that means rolling 3 or 4 or 5 different procedures all into one surgery. For example, doing an osteotomy to realign a lower extremity or offload an area of cartilage damage, transplanting a donor cadaver meniscus in what's called a meniscus allograft transplant, performing cartilage grafts for focal defects or potholes in the articular cartilage, and then often doing revision ligament reconstructions. So someone had a prior ACL and retore, for example, and we have to kind of work around the old surgery and come up with the best solution possible. In some cases, there's ways to augment that as well. There's a lot of interest now on the lateral side of the knee, for example, lateral extraarticular tenodesis, anterolateral ligament reconstruction, but we basically try to do everything we can to give people back the best kind of knees possible, and in some cases even return to sports after really devastating injuries. Similarly, in the shoulder world, with instability, for example, people have an arthroscopic stabilization and redislocate and then need another option, and so the Latarjet procedure, where we actually transfer a bit of bone to the front of the shoulder socket to provide stability, has been a real benefit for a lot of my patients. I see a very high number of very difficult rotator cuff tears. In some cases, rotator cuffs that are beyond repair now. We're doing what's called a superior capsule reconstruction. Take a big, thick piece of donor tissue and attach it in the shoulder in place of the rotator cuff, and then attach the rotator cuff around it. And that's really been a great boon to really solve a very difficult problem. Along those lines, I see a number of complex and revision rotator cuff tears, or in some cases people are told, hey, I don't think we can fix this, but then it turns out at surgery we actually can repair the rotator cuff primarily, in often the use of adjunct patches or dermal allografts and biologic agents can be helpful in terms of trying to optimize our outcomes. And finally, revision shoulder replacements. Sometimes components loosen or wear out and a revision surgery is needed, and these can be challenging cases as well. But often can be very rewarding in terms of how much better people can get with kind of a complex revision surgery.